Hello, everyone. My name is Renad Batis, and it's my great pleasure to kick us off for this next section of our event today. I'm an implementation scientist. I'm newer to the HIV world, and I just so enjoyed the presentation by our colleagues. I just want to highlight, I think that they did a remarkable job showing the power of public-academic partnership, implementing a paradigm-shifting intervention that is person-centered and focused on going beyond brick and mortar with thoughtful evaluation. So in this next section of talks, we're going to be spotlighting our community partners at the Philadelphia Department of Public Health and researchers across Philadelphia so that we can spark thoughts on collaboration and how we might apply some of the insights from the plenary that we heard in Philadelphia. Each person will have 10 minutes to speak, and then there will be 5 minutes of discussion. Please use the Q&A feature while the person is speaking so we can go right into discussion for each person's talk. So I'm going to start by introducing our first speaker, Javontae Williams. Javontae is a nurse, academic lecturer, and public health advocate. Williams leads the Philadelphia Department of Public Health year-long community planning to end the local HIV epidemic. The EHE initiative seeks to reduce new HIV diagnoses by 75% in 5 years and 90% by 2030. We're so pleased to have Javontae. Thank you very much.
Thank you so much. And thank you all. I'm going to leave my camera on mute because it helps my internet run a little faster, but if you're looking to know what I look like, there's a picture of me smiling. Thank you so much for inviting us to be a part of this symposium and workshop this morning. It is an absolute honor and pleasure to present to you some of the work we've done over the last year here in Philadelphia. And I also want to recognize that while we have a couple of our AACO colleagues presenting today, there are many of us in the audience attending. So I want to send a special shout out. And also I recognize some of the names from the attendees. It's like a family reunion now because you all have been, on my horse and pony show with me as we've done these community events to listen to community and plan for ending the HIV epidemic. So to those of you who I don't recognize in the attendees list, do me a favor and just drop in the chat where you're coming from and what organization you're representing, and we can all get to know each other a little bit better. And so today I'm going to be talking about being radically unstuck, how we end the HIV epidemic through innovative implementation science. And I'm the EHE Planning Coordinator at the Philadelphia Department of Health, as was mentioned. We'll give you a brief overview today about where we are in terms of planning to end the HIV epidemic, what we've heard from community. I'm going to offer a biased view of our current research enterprise and how we get unstuck. And then we'll have a conversation with our director about priorities for AACO funding as we consider EHE implementation in Philadelphia. But we have to acknowledge the effect of COVID-19 and HIV, right? The effects on mental and emotional health, the unique challenge for service delivery. But also, as I remind people, this is an excellent opportunity to stop and acknowledge that this crisis can be an opportunity for us to champion changes in our care system. And then we hear people talking about going back to normal. What is normal, right? Is it tremendous disparities between populations? Is it funding considerations based on program preferences and not data? Or HIV-related work that's disconnected from the social determinants of health? The truth is that things have been abnormal for a long while, and we've just learned to live with it, or even worse, ignore the challenges. But what would happen if we dreamed bigger, if we replicated what works, reached for what was in our grasp, such as treatment as prevention, pre-exposure prophylaxis, if we reimagined our work in communities, focused on what we have the power to improve, and addressed our organizational differences to champion what we have in common. And that leads us to our year of planning to end the HIV epidemic here in Philadelphia. It's a federal initiative to reduce new HIV diagnosis by 90% in 10 years, and more importantly, 75% in the next 5 years. And we want to do this by diagnosing all of people living with HIV as early as possible. We want to treat people rapidly and effectively to reach viral suppression. And we want to prevent new HIV transmission by using proven interventions such as PrEP, InPEP, and syringe service programs. We want to respond quickly to HIV outbreaks to get needed prevention treatment services to people who need them. And so how did we get here? The Philadelphia plan didn't start from zero. We started from a robust community planning effort led by the Office of HIV Planning in collaboration with the Philadelphia Department of Health and the HIPC. It's based on the 2017 to 2021 Philadelphia Integrated HIV Prevention and Care Plan. We also listen to those who we serve with direct input from consumers, HIV prevention and care programs funded by Philadelphia Department of Public Health, and it's been ongoing and extensive. And we're looking to community to lead the way. We continue to rely on community engagement activities, even during the pandemic, to inform HIV planning, prevention, implementation, and evaluation. Other forms such as listening sessions, community-based staff, and the Philadelphia Big Idea Survey, which was really a survey that's actually still live at ehe.hivphilly.org. And you can leave your answer to one question. What's your big idea to end the HIV epidemic in Philadelphia? We might not be able to end the ramifications of HIV/AIDS with a cure or a vaccination, but we can end the epidemic as we know it. And so that question is really central. What is your big idea? Recognizing that all Philadelphians have a part to play in this process. And so the plan is available for you to read on the city's website. Just Google search HIV Philly, and you should get a hit that brings you to the plan. But the three things that stand out to me over the last year of conversations are stigma, housing, and radical customer service. If we tackle these three things, from what I've been hearing from community, we could go a long way to ending the epidemic. Stigma still permeates every portion of our continuum. And so we need to reduce HIV stigma through education, awareness, anti-bias programs. We need to make sure that there's an interdisciplinary focus on the challenge of housing, which will require partners outside the Department of Public Health and across service providers. And we need to be honest about providing radical customer service to create meaningful relationships with those we serve and lower barriers to engaging in prevention and treatment services. And so this is my biased view of our current research enterprise, right? It starts at stage one, understanding a need. We go to stage two, ask a relevant question. Stage three, apply for funding. Stage four, we perform our studies and evaluation and then publish the results. Stage five, institutional advancement, right? You get a tenure or promotion track, job. And stage six, recruit a mentee, graduate students, and repeat it. But notice where the need is. It remains in the center of a circular cycle that doesn't really break anything, right? And what I'd like to introduce is a framework for getting unstuck, where we build community coalitions. We understand a need and ask a relevant question. We receive funding. We perform our work. But the last step of that would be to reach back to community with practice and implementation science. Philadelphia's plan is about addressing structural barriers. People are not broken. They're forced to engage broken systems. And so when we're prioritizing Philadelphia's EHE plan, which will look different than other jurisdictions, we need to answer the question of how do we move a mature, diverse system forward? I'm reminded of a story. And if you've talked to me in the last year, you know I like stories about catfish and codfish. And people love to eat codfish, right? And so when codfish were first being shipped, they froze them. They noticed that the flavor was lost during shipping. And somebody came up with the idea to put them in tanks and ship them in actual seawater. And even then, the codfish would arrive at the market 3 or 4 days later and would have lost much of their flavor, and also their flakiness, becoming soft and mushy. Finally, a creative person solved the problem, and the codfish were placed in seawater tanks with a couple of catfish. Now, the catfish is the natural enemy of the codfish. And so during shipping, the catfish would chase the codfish all around the tank the whole time. And when the fish arrived at the market, they were fresh as the day they were caught, with no loss of flavor or texture. You see, the catfish kept the codfish from becoming stale. The catfish kept them fresh. As we plan to end the HIV epidemic, we're starting off like these codfish. We've become a little stale and stagnant. We've lost our flavor. We're clocking into our clinics and practice, doing the same things every year, applying for the same grants every year. But what we need are some research catfish. Just like the catfish with the codfish, we need fresh insight from researchers that would help our programs be alert, that would chase us with data and keep us active. And maybe it's difficult to hear about these things that the catfish researchers tell us and the challenges, but because of these difficulties, it will make us grow. Everything continues in a state of rest unless it is compelled to change. This ending the HIV epidemic plan is an opportunity for us to change our system. Thank you for your attention. I want to toss it over now to my colleague, our director, Coleman Terrell.
Hello, everyone. I am very honored to be asked to talk here about implementation priorities for ending the HIV epidemic in Philadelphia. Also really grateful to hear from colleagues in Baltimore. I always learn new things from Baltimore and things to take and steal and bring back home. So I'm going to go quickly through some things to get you thinking about how to prioritize things in research in Philadelphia. Next slide. So this is rates of newly diagnosed HIV in Philadelphia over the past 5 years. The top line are men who have sex with men, and we're making some progress, not much. You see in the middle line an outbreak among people who inject drugs and relatively low levels of progress with heterosexuals. The point here is there are significant disparities in how HIV affects programs, and we really need to use data to focus our efforts. Next slide. And this is the Philadelphia care continuum based on surveillance data, and you'll see that over the past 4 years here, we have had limited success improving linkage. The number of people retained in care has basically been stable, in care and retained in care basically stable, and some slight increases in viral suppression. We're at 58.8% in 2019. Our goal is 92% in 5 years. So we definitely need help in moving the system. Next slide. And I just want to show you what the system is in Philadelphia, because I think it's important for researchers to understand that there is a very large system in place that has to be addressed and dealt with. And so we identified about nearly $100,000 of public funding, and that excludes ADAP research and third-party and 340B money that is available for HIV care and prevention and surveillance in Philadelphia. About 53% of that comes through the AIDS Activities Coordinating Office. Notably, only 6% of that money, about $6 million, is new EHE funds from Ryan White, CDC, and the Bureau of Primary Health Care for Philadelphia. So we clearly need to engage the entire system if we're going to end the epidemic. This additional funding is just to leverage things. And then in terms of the system in Philadelphia that we fund out of AACO, we have like 11,000 Philadelphians being served with Ryan White funds. That's with about $8.5 million. We have a huge medical case management system serving nearly 9,000 people, about $8 million there, and a very large community-based testing program that did about 19,000 tests last year at a cost of about $3 million. So this is sort of the basis in which you are putting research projects and thinking about how to improve the system. Next slide. And this is, I think, one of the more important slides. It shows on the left our estimates of the number of people by risk and race with PrEP indications. And you'll see that men who have sex with men are by far the largest group, and Blacks are in blue at the bottom, Hispanic in orange, and whites in gray at the top. And so that this is really what we're looking in terms of prevention of just disparities in who needs to have access to PrEP and prevention services. And notably in Philadelphia, we had a project that was a comprehensive prevention, care, behavioral health, and social services for men who have sex with men of color. $5 million over 7 years, and we were able to navigate 174 men who have sex with men of color to PrEP. It was only 38% of the people being served by this project. We had put out money for 7 programs, and we had 7 programs applied. There's a real lack of capacity in the system to meet the needs. We moved to some clinic-based PrEP programs and navigators, and we have 7 clinics doing that, and only 29% of the patients being navigated are men who have sex with men of color. And in our HIV testing program, we set goals sort of based on these PrEP estimates. We wanted to reach 64% of our testing among men who have sex with men, and we're at 24%. And I just point this out because I think it is really important to think about who it is that we are focusing services on, and how can we get more organizations ready and prepared and willing to serve populations of great need. Next slide. Another thing I wanted to highlight is some results from our Data to Care re-engagement project. People doing field work re-engaged people who had been lost to care and asked them why they were out of care. We divided this up into 4 domains, and we found that most of the domains were patient rights and then provider barriers. And this is what I want to focus on because we can change the provider barriers. And notably, the biggest barrier noticed by anyone is couldn't get time off from work or school. And you'll see other things about hours and location being inconvenient, 27% of people. And notably, we put an RFP out for improving care, and no one suggested extending their hours of services. So we really need to switch the system. So next slide, please. So some of the principles are that we need expertise in evaluation. We need help and expertise to evaluate an old and established system. The EHE is not an add-on. We need help with engagement, and engagement and messaging to key populations is going to be critical. We need people to take a public health approach and follow the public health data and use EHE funding to leverage system changes. And we need to look for scalable interventions and look for what works in research. Will it work in practice? Next slide. So some of our other priorities are help with us in our monitoring and evaluation of our programs and looking at some of our large systems. For example, medical case management is a system in Philadelphia that's been around for 3 decades. We've tried rechanging the model. It really is something that needs to be looked at and evaluated. HIV testing in clinical settings is really critical for ending the epidemic, and there's very little uptake of it in clinical settings across the city, and we see big gaps there. We have turned to biosocial testing is what we're really looking for in the our plan for clinicians, and that's looking, at least if you can't do routine screening, screen people who have diagnoses of syphilis, gonorrhea, chlamydia, hepatitis, et cetera, unintended pregnancy, things like that, so that we really get people who need HIV testing. We need to assess the effect of telemedicine, and we are trying to start sort of multi-service sexual wellness clinics, and evaluating those will be very important too. Next slide. So we need help developing non-stigmatizing messaging. This is for providers. We need to think about how we talk with patients in providing PrEP. We need to think about incentives. We need to increase the capacity of agencies to provide services to the populations at greatest risk and the greatest difficulty accessing services. We are looking at some vending machine ideas for harm reduction materials or for storage of medications. That would be a great project to look at and really evaluate the cost effectiveness of that. And we have an HIV self-testing program, again, that we have some evaluation going on, but really could use more. And next slide. And the biggest thing is, as we keep on going back to, is addressing structural barriers. We need to fix broken systems, not broken people. And we need to really learn how to assess the structural barriers in HIV care and prevention programs. The client's not the problem, the system is. And we need to really always look about how we can make access easier. We don't need navigator. Do we need navigators navigating to another navigator? We probably do, but we also need to change the access to systems. And so finally, next slide. We really want you to read and give feedback on our plan. We have a RFP that just went out, and it would be great for you to read that to see where we're going. To pay attention to our data programs, we have the medical monitoring project. We have our demonstrated expanded interventional surveillance project, National HIV Behavioral Survey. Think about your research plan fits into the existing, how it fits into the existing system and the plan changes we are making. And we really need your intellectual labor, your training, and your expertise to drive us to changes that will end the HIV epidemic. Thank you.
We are so tremendously lucky to have had our partners from the Philadelphia Department of Public Health here to share their vision and to help infuse their thoughts into next steps. I want to apologize. I didn't have a chance to introduce our second speaker, Mr. Coleman Terrell. So I'm going to do that now. So please send in your questions as I introduce him. Mr. Terrell is the director of the Philadelphia Department of Public Health AIDS Activities Coordinating Office, AACO, and is responsible for the administration of federal, state, and local funding for HIV care in a 9-county region and HIV prevention and surveillance in Philadelphia. Mr. Terrell worked at AACO in a variety of roles before becoming director in 2014. And before working for the health department, he was an early member of ACT UP Philadelphia, and as you can see from his presentation, is committed to ending the HIV epidemic. So thank you so much to Javontae and Coleman for their wonderful presentations. We have an opportunity for some questions, and I see that there are some, so I'll start with Nikita's. Can you give more information on how you addressed radical customer service within clinical settings?
I'll take that question. Yeah, and then I'll toss it to Coleman because I think mine is more an experience, right? And during this process, I was at one of our local clinics, and I was there to meet a colleague to have a discussion over lunch. And I walked into the reception area, and I was greeted with a very rude, abrupt nastiness, right? It's like, who are you here to see? Now, I could have, in that moment, whipped out my little temporary badge for the Philadelphia Department of Health and threw some authority around and be like, I'm the planning coordinator for the ending the HIV epidemic. Your clinic budget has just been zeroed out. But in that moment, I realized that this person is doing their job in the way that they think they should be doing their job. They have no idea that their reception of me has impacted my day. Right? They're just doing them. And I think to really hit a reset button and to acknowledge that every interaction you have is a chance to serve that other person will implement this radical customer service notion, right? And you think of it as the Chick-fil-A versus the rest of the fast food industry model. As problematic as Chick-fil-A can be, every time you say, thank you, and they respond with, my pleasure, it's my pleasure. They could be having the worst day ever. It's my pleasure. And so what does it look like to implement, even if we have to get folks to fake it until they make it? When someone comes into your clinic who maybe smells like they haven't showered in a couple of days, right? Who has been resistant to your phone calls, you know, after months and months and months of reaching out to them. And then finally they show up and act as if you have the problem. You know, and for you to respond with, my pleasure, that's what I mean by radical customer service. But I take that even a step further into AACO's work with our subrecipients. When we are managing programs and evaluating services, right, what does it look like for us to offer that same humility that same customer service to the organizations that we serve. And so if you start at that level, right, of the customer or consumer interaction, and everybody from that ripples out with a my pleasure, it's an honor to serve, I'm happy to have a job. That gratitude will change the outlook of how people engage with us. And I think that that is the piece that's missing. Philadelphia is a hard place to live, right? We got a certain air about us, and I don't want that to ever change. The name of one of our mascots is Gritty. Like, I don't ever want that to change. But I also want us to become known for the Philadelphia compassion and the Philadelphia care of the people we serve. Coleman, did you have something to add to that?
Yeah, I think this radical customer service is really everything. And I think what Javontae said is really important. And I think is what you see in a great navigator case manager like Nikita. I think, though, that there are some structural things we can do. Why, when you call, do you have to leave a voice message to make an appointment? Why do you only get a medical appointment during the hours that you have to work? That is at the provider's benefit and not the customer's. What would happen if there was someone who went around the waiting room and said, you know, I see you've been here for a while, the doctor will be with you soon. There's some really simple things, and then there are probably some very complex things like, you know, opening a clinic on a Saturday morning and publicizing it that it's open. And so I think that really looking at how we make clinics accessible to people in their lives without making a lot of changes. So that I think is really important.
Thank you. I really appreciate you guys answering that for me. I mean, for myself, with me working and doing all the community health worker, being on the ground, it's like I find myself always doing that too, with having to navigate and be like, hey, oh, so you got that from who in the back? Who said that to you? And trying to make sure, like, hey, everybody's able to communicate accordingly and actually having those frontline people, because that could be such a barrier with all of our patients. The first person that you talk to can ruin the rest of your day. So thank you. I do appreciate that.
And I'm not going to, I just want to add, I'm not going to be so Pollyanna to understand that, you know, this will not cause increased burnout. In my background in nursing, there's two types of empathy we acknowledge, right? There's that deep empathy, which comes from the soul, almost like someone who cares about, it takes a lot of energy out of you. And then there's this surface level of energy where it's just a part of my job. I would be happy with either. What we're seeing now is that people are not showing empathy, right? And they're not offering that service at the highest level. And we have to start to look in a direction that allows folks to show a higher level of empathy.
Thank you for that wonderful question and the fabulous responses. Dr. Cargill said, I love your concept of radical customer service. This is at the core of what we have to do to capture more people. It's basic common decency, and she recommended a great book, The Empathy Gap. We do have another question from Dr. Michael Blank. He's wondering, and he addressed this to Coleman, how there are more people who are virally suppressed that are retained in care in Philadelphia. He's wondering if there's a case definition problem with retention in care, and whether it is seeing a provider in the last 6 months, and wondering if that's too strict of a definition. So maybe Coleman and Javontae, you can weigh in on that.
Yeah, so we look at in care, which is one visit in the past 12 months measured by a lab, and retention in care is 2 visits in the past 12 months. It is more than standard of care for people who are durably virally suppressed. So it's not surprising that you have some people who do not appear to be retained who are durably virally suppressed. So when we do data to care and reach out to clients, you have to look and see what's their viral load, and are they really out of care, or are they just someone who doesn't need as intensive follow-up.
Thank you for clarifying that. I see a question from Keith Carter. What tools are you using to evaluate your case management model?
Well, Keith, it's a good question. We look at some of the basic measures you've seen. Supportive retention in care and viral suppression are the outcomes. We have a complicated system that includes community-based case managers and case managers in medical settings. And it's one of my pleas to the CFAR to think about looking at some of these big old systems and how we could pick them apart and look and come up and see where they're effective and where they really need radical change.
Wonderful, thank you. And Alex Oakes, and apologies if I did not pronounce that correctly, notes radical customer service is critical, especially for young folks. It creates a sense of safety, belonging, connection, and relationship with a clinic, which they might see as their healthcare home. Eye contact, using their name and correct pronouns is essential. Thank you for that comment, Alex. So we have one more minute, and I'm not seeing any more questions coming up, although I hope that we can continue to engage. It's so meaningful to have our partners and leaders at PDPH share what keeps them up at night and how we can be helpful to them. So thank you so much for these two great presentations. And I'm going to move us along to the next presentation, which will be given by Dr. Sarah Bass. So I'm going to go ahead and introduce Dr. Bass and then turn it over. So Sarah Bass is an associate professor in the Department of Social and Behavioral Sciences and director of the Risk Communication Lab in Temple University's College of Public Health. Her research utilizes psychographic commercial marketing techniques to develop highly targeted, persuasive messaging to affect health decision-making and test communication interventions in vulnerable populations. So please do send along your questions as you have them, and thank you so much to Dr. Bass for joining us.
Good morning. Whoops. It's great to be here today, and I'm going to talk a little bit about a project that we're doing that is trying to get women who inject drugs or who are sex partners of men who inject drugs to be engaged with PrEP. This is a project that was funded by the National Institute on Drug Abuse, and I just want to acknowledge all the people that have been part of this. This was an R34 development grant, so we've done really 2 years of a lot of formative work, really talking to participants, people who have substance use disorder, as well as staff in community-based organizations, and specifically Prevention Point Philadelphia. So as most of us know, about 93% of PrEP users, and it's probably a little bit less now in 2020, are men. And so women in general have not been engaged in PrEP, and women especially who inject drugs have not been engaged in PrEP or really focused on too much in the realm of HIV prevention services. And there are a couple reasons for that. They're both at risk because of needle sharing issues, but also sexual behaviors, especially if they participate in sex work as well. And they experience, as many people do, stigma and discrimination, but also I think, extra stigma around drug use and poverty and homelessness. There also is kind of a cultural phenomenon within the drug-using population of being what's called second on the needle for a lot of women, especially if they have a primary male partner, where they're always second, which then also puts them at higher risk. And as we know, PrEP shows promise to reduce some of this HIV risk, but very few women who inject drugs are actually on PrEP. I think there are a couple special issues in Philadelphia too that I just want to highlight. One is just fentanyl in general. So Philadelphia is a distribution point for fentanyl in the US, and it's found in a variety of different drugs. It also, the high of fentanyl diminishes much more quickly than heroin, which causes people to inject many more times a day than they would with heroin. And the latest data, as Coleman just showed, is that we're seeing an increase in HIV cases where we, had a fairly consistent rate of HIV among people who injected drugs in Philadelphia for a long time, and this is the first time we're starting to see that increase again. So the objective of this study was to try and understand what those barriers might be to getting women who inject drugs into PrEP care and then develop and pilot test an intervention that would be specifically community-based in Prevention Point, Philadelphia. So the study design, as I said, it's an R34 development stage. So we did a lot of formative work. We did qualitative focus groups and interviews. We did surveys and used my commercial marketing technique, which is called perceptual mapping and message development. And we're now in phase 3 where we're piloting a RCT in Prevention Point, Philadelphia, and looking kind of at those implementation and sustainability issues. This project is called the Peace Project, so PrEP Empowerment Achieved by Counseling and Education. And there are a couple components. So the whole intervention is embedded into the existing Prevention Point Philadelphia services, which we thought was very important for sustainability. So they currently do HIV testing. They do PrEP counseling, so they've just started a PrEP counseling project. They do medical evaluation and blood work, and then they also do PrEP distribution through their medical clinic. So for this project, we have an intervention group that's randomized where they get specialized PrEP counseling that addresses a lot of the issues that we found in the formative work. And they do 4 sessions with the PrEP counselor over a 12-week period. They get specialized health communication materials, and then they get weekly text messages 3 times a week that are those supportive messages. So I think we heard that this morning a little bit about how important that piece is. The control group is getting the same intervention that is embedded at Prevention Point, where they do PrEP counseling with people. And they are getting some reminder text messages. So they get 1 a week that's basically encouraging them to pick up their medication. Just to give you a sense of, some of the intervention, this is the counseling session, scripting for the intervention. They get recap information, just kind of going over those main things. So you can kind of get a sense of some of the things that we're doing. And this is some of the text messaging. For the control, they're using a DAP form, data assessment plan form for every PrEP navigation session. And then this is what their text messaging might look like. So if we think about it from an implementation perspective, if looking at kind of stage of implementation completion with pre-implementation, some of the things that we did, so a lot of meetings with Prevention Point staff trying to kind of think about logistics and what would happen, a timeline and documents, finalizing those intervention components. We had a lot of staff changes, so we had some issues in that was an implementation issue. And then I think, what the big elephant in the room is really COVID, and how that then affected how we were able to go into Prevention Point and actually do recruitment. We're now in the early stages of recruitment where we've done, kind of training of staff, tried to troubleshoot problems. So a lot of problems in the first, 3 or 4 weeks, trying to understand space issues and those kinds of things, and doing this kind of soft open of the recruitment. And now I think we're, into regular recruitment of the study. What's going to happen in the future? We'll see. I just want to kind of end talking about some of these real specific implementation challenges in a community-based program like Prevention Point. So one of those issues is just eligibility. So one of the eligibility criteria is that they do have to have a cell phone. Because this is an R34, I don't have the budget to be able to provide burner phones or other kinds of things. We're giving everyone some extra incentive through to be able to buy minutes, but if they don't have a cell phone and can't get text messages, so we are having an issue with that. Just recruitment in general, so time to get through kind of all the steps of the process, and just the attention of participants. It's very hard, especially when you're working with people who are using substances, to get them through 2 or 3 hours of things. So they have to go through eligibility and the consents, and they have to get HIV tested, and they have to do a baseline survey, and then meet with a PrEP counselor. It's a very long kind of period of time. But then the challenge is to actually get them back in to continue the process. So that retention, I think, is also important, and we're kind of working through some of those issues now with the retention and trying to deal with that. For COVID, I think there certainly have been a lot of restrictions as well. So just, in general at Prevention Point, the number who are allowed into the drop-in center, the building is reduced because of COVID. There are staff restrictions at Prevention Point, so they can only have so many staff in the building at once, which then minimizes some of the services, which means that, maybe some days they don't have an HIV tester, or some days they don't have a phlebotomist, and we have to kind of troubleshoot some of that. And then certainly the Prevention Point services take precedence. So it only allows us to be there right now 2 days a week. It looks like we're going to get a third day, which is great, but it also, there's space issues and things like that. So finally, the last thing is just thinking about kind of from an analysis plan in implementation, which is, how are we actually kind of looking at this from an implementation science perspective, and how are we going to evaluate it? So this just gives you a sense of, really looking at things like participant recruitment and study adherence and study fidelity, and, our plans to collect this type of data throughout this intervention, using both qualitative and quantitative methods, and then kind of trying to set up this implementation system so that we can track recruitment and retention issues. So I'm going to stop there. This is my information if anybody is interested in getting a hold of me, or you can certainly follow us on social media. And I look forward to answering any questions.
Thank you so much for that fantastic presentation. Everyone, please send your questions in the Q&A or the chat boxes. While we wait for the questions to come in, I'm curious, as an implementation scientist, where do you feel that the frameworks and the outcomes that you showed us kind of enhance the kind of broad implementation science approach? Where do you think it enhanced your approach? Where did it fall short? What did you wish implementation science could offer that it didn't? I'd love to hear your thoughts on that, in thinking about the application.
Yeah, I think that's an interesting question. I think part of implementation science is a lot of it is set in clinical settings. And so the way that they think about implementation is very rigid within clinical settings. And I think when you're going into a much more community-based setting, every day is different in a community-based organization depending on what's going on. Like Monday we were supposed to go in and recruit, and their power went out and they had no internet, and we couldn't get on RedCap, right, because they didn't have an internet. And so those are the kinds of things that I think implementation frameworks tend not to address.
Thanks for that great thought. I see a question from Florence. She asked, one of the major barriers to initiating and maintaining retention in PrEP is people's HIV risk perception. If people don't feel that they are at risk for HIV, buy-in is low. Does your intervention address this, and if yes, how?
It does. So part of the formative work we did was really to talk to women who inject drugs to try and understand exactly those kinds of things. So not only HIV risk perception, but kind of their perception of who should be on PrEP. So there's a lot of, well, I don't really need it, but she does, and so there's kind of this almost optimism bias that goes on in that way. So a lot of the commercial messaging techniques that I use create those kinds of messages. And so all of the materials, the counseling sessions, each counseling session kind of has different focus, and then the text messaging throughout the 12-week session.
Thank you. And while we wait for more questions to come in, please send them in the Q&A. I noticed that in the development process, you did a lot of optimizing for implementation and engaging with consumers and stakeholders. And I'm curious if you could reflect on that process at all, and how you think things changed based on how you were initially thinking about things versus once you had your stakeholder engagement process.
Yeah, that's a good question. And I think that, a lot of things changed. Our original idea at that point was that women were going to have to go to Temple Hospital or Episcopal Hospital to get PrEP prescriptions and meet a doc, because at that point in the process, they didn't offer PrEP through Prevention Point. And so we had to really kind of switch gears in thinking how we were going to implement the intervention within this community setting as things changed throughout the 2 years of the grant. So I think that is always something that happens when you're working in community settings, because they don't stay stagnant.
Wonderful. Thanks for sharing that. I think that that's such a key insight that's really important as we think about implementing in the community. And I think even folks who may not identify as being implementation scientists or wanting to do that specific type of work when you're developing interventions, optimizing them for the eventual implementation is so key. So thanks very much. I don't see any additional questions in the Q&A, and we're almost out of time. So I'm going to thank Dr. Bass so much for the fabulous presentation, and we'll move now to Dr. Laura Starbird. So I'm going to go ahead and introduce her, and then hand the mic over to her. So Laura Starbird is assistant professor in the Department of Family and Community Health at the University of Pennsylvania School of Nursing. As a public health nurse, her research examines implementation, including economic implications of strategies to improve care delivery for women and communities affected by substance use, HIV, and hepatitis C at the organizational level. So Dr. Starbird, you can go ahead and take over.
Great, thank you so much. Let me get this pulled up. So I'm actually going to focus today on hepatitis C and talking about how we can look at using nurse case management in HIV care settings to improve the hepatitis C care continuum among co-infected patients. First, I just wanted to acknowledge some of the funders and my collaborators. I was actually at Johns Hopkins University when I did this, and working with Jason Farley, who you heard from this morning. So we all know that the hepatitis C care continuum among people living with HIV has not been great in the US. And even though we've made some strides since the advent of DAAs, we're still looking at a lot of patients in need of getting a cure. And we know there's a lot of barriers to engaging in hepatitis C care. So for example, some of these include low hepatitis C knowledge among the general population. We haven't really caught up yet to understanding the implications of the new treatments, and a lot of people are still really bogged down by the old perceptions of hepatitis C treatment, which involved at the time interferon injections with a lot of side effects and really low efficacy. So we're really in a place where we need to move towards improving Hep C knowledge. At the same time, perceived threat of Hep C is pretty low because a lot of people don't have severe symptoms until they have liver disease. And so it's difficult, among a lot of competing demands to get somebody to prioritize hepatitis C if they're not necessarily feeling sick. So some of these competing demands, we heard about these from Coleman earlier. They can include work responsibilities, caregiving responsibilities, but also for people living with HIV, prioritizing treating their HIV and engaging in HIV care or maybe other comorbidities. And then we have this potential issue of HIV and hepatitis C drug interactions. So ARTs can interact and be contraindicated in conjunction with some DAAs. And so that's something that we need to consider when it comes to treating patients, because especially a lot of our patients that may be on some ART regimens that are a little older may be more likely to experience some interactions and also be hesitant to change those just so they can treat Hep C. We're also still lagging a little bit behind in provider expertise, especially outside of specialty care settings. So, our infectious disease providers and hepatologists are very well versed at this point in treating Hep C, but in primary care settings, that's not necessarily the norm. And part of the reason it's not necessarily the norm is because a lot of Medicaid programs still restrict access to hepatitis C care to specialists. Which is not necessarily evidence-based. We know that primary care and nurse practitioners can successfully provide hepatitis C care but we still have a lot of challenges in accessing specialty care in our healthcare system, and in general, navigating the healthcare system, as we've heard, countless times this morning already, is not easy. So thinking about how we can address some of these barriers, we really wanted to focus on perceived need and really seeing what we can do to improve hepatitis C knowledge, but also looking at these enabling resources, again, that we've heard about this morning, and really helping people to minimize some of these barriers to navigating the healthcare system in places that we can to improve their use of health services and their health status. So this was called the Care to Cure study, and we were really asking 3 questions. The first was, does nurse case management improve linkage to an HCV treating provider compared to usual care? Does nurse case management decrease time to HCV treatment initiation compared to usual care? And then what patient level characteristics would predict success across the HCV care continuum among co-infected patients? So I'll just talk about what usual care looked like briefly, and you've actually already been introduced to this clinic because it was the Bartlett's practice where Dr. Farley and Nikita did their intervention pilot earlier. And so this practice included co-located HIV and HCV clinics within the same building, and this was actually a change. So implementation-wise, when we started the study, they were actually separate clinics down the hall from each other with separate providers. And about halfway through our study, they merged into a brand new practice, which meant that a patient could literally, walk from one room next door to see a Hep C provider. And we thought that this was going to be a really wonderful benefit to patients because, in fact, on the Hep C side, we decided to open it up so that patients could just walk in from the HIV clinic and see a Hep C provider without having an appointment, thinking this is going to open up all kinds of opportunities and patients are really going to, engage in Hep C care. Interestingly enough, we offered this service through this study to every single intervention participant, and not one actually took us up on it. So that was, just interesting to think about what we think from a clinic perspective will be effective and what patients actually think. So because this was a Ryan White funded clinic, there was access to nurse case managers and social workers on the HIV side, automatic appointment reminders in the form of a robocall, and then we gave people a CDC hepatitis C fact sheet. The case management intervention included several additional components on top of usual care. One was just simply making sure that they had a referral, that the patient had a referral for a Hep C provider. We provided strengths-based education, which is an evidence-based approach that we've seen work in the HIV world, and so we adapted it to hepatitis C, really assessing patients' strengths and helping them to set goals for engagement in Hep C care. Then we helped patients schedule appointments, make appointments, provided additional appointment reminders, and then had a nurse help patients through the process of coordinating changing their ART if they did, in fact, engage in Hep C care and have a drug interaction present. So we looked at most of the hepatitis C care continuum, but because we had a 6-month follow-up, we really weren't able to robustly look at SVR, the cure at the end. Our participants were fairly sick, and that's because, and not really well engaged in care, and that's because essentially by that point, by the time we started the study, the clinic had already cured a large proportion of their patients, especially those who were really well engaged in care. And so among our patients, you can see here that less than half had an undetectable viral load, despite most of them being actually prescribed ARTs. About half reported some sort of substance use and a quarter of some injection drug use, and about 40% reported drinking alcohol. So, the short answer to our first question of does nurse case management improve linkage to HCV care is yes. We did see a significantly higher proportion of patients who got nurse case management linked to care, but I will point out that these numbers are still not great, and this is a really highly supportive setting, right? And it gets back to that brick and mortar issue that we heard about this morning, that despite all of the services we were providing patients, we still got less than half to actually link to care. We did also see a significant improvement in patients who were scheduled. You can see most patients had a referral, but among the usual care, there's this really big drop-off in the clinic setting where they have a referral, but they never actually schedule an appointment. So we didn't see any differences in time to treatment initiation, mostly because we didn't have a large enough sample size to look at that. But we did have some interesting findings in terms of patient characteristics associated with the care continuum. So I think the most surprising finding was that patients who reported that they drank alcohol were 4 times more likely to schedule an appointment linked to care and be prescribed treatment. And this was really surprising to us because it was contradictory to prior literature. But in talking to the HCV providers and talking to the patients, we realized that it was probably coming down to the fact that patients were actually listening to their providers when their providers told them, look, HCV and alcohol don't mix, and so patients took that and they said, well, this is great. I can cure my HCV and then I can continue drinking alcohol. So that was just really interesting to look at. And another thing I'll point out is that people who knew someone who had cured HCV were more likely, 5 times more likely to be prescribed treatment and 8 times more likely to initiate treatment than if you didn't know someone who cured HCV. So I think this is really pointing out some opportunities for us to engage with social networks and peers and that community-based knowledge. And then unfortunately, patients who were taking medication for opioid use disorder were 75% less likely to be prescribed HCV treatment than patients who are not taking MOUD. And I think this is just indicating, again, the sort of disconnect between our substance use services, because patients in this group are actually connected to healthcare, right? But it's not HCV care, and we really have that lack of integration between substance use services and HIV and HCV care. So I'll just really quickly go through some reasons that providers said they didn't want to refer their patients to HCV care. Just thinking about a provider buy-in issue that we encountered, which is if you look at the gold and the dark blue, most patients didn't get referred to HCV care because their HIV provider felt like they weren't engaged in HIV care enough. And the problem here is that that's not actually evidence-based. And in fact, we saw anecdotally that patients who were not necessarily taking their ART, but were able to adhere to HCV treatment would then have the self-efficacy at the end of being cured for HCV and eventually get into taking their ART, but actually had the opposite effect. And then insurance issues, of course, were a major issue, and we can talk about that in the discussion. But patients had pending prior authorizations, or at that time, Maryland Medicaid didn't allow anybody with a Medivir score of less than F2 to get treated. So, I want to leave some time for questions, but to just give some brief recommendations that we need to think about case management support spanning the entire care continuum. We had a big drop-off in, yes, we got patients linked to care, but if we left them at that, then our patients who actually initiated treatment were pretty small. We should really think about capitalizing on social networks, enhancing treatment pathways for people who drink alcohol, and then how do we examine the role of case managers in hepatitis C care? And did you really need a nurse to do all of this is a question that we often think about, because, if you look at what was actually most impactful, it was really the navigating the healthcare system. And I think this really points to the idea that, especially if we're thinking about cost and best use of people's time, my colleagues and I have done another study alongside some of the NIDA Clinical Trials Network looking at we can actually see a fairly low cost with using a very similar strengths-based education care facilitation model with similar people, but with a non-nurse case manager. So I will leave it at that and open it up for some questions.
Thank you so much, Dr. Starbird, for that excellent presentation. Please send your questions in the Q&A. I see one from Keith Carter. Did any cured HCV patients become reinfected?
Not in our study. So we had 9 of 12 patients who initiated treatment in our study were cured. Now, because we were looking at a 6-month care continuum time frame, we really didn't have enough time to assess whether somebody was going to, be reinfected. I think generally reinfection is very low, but in our study, we couldn't really assess that.
Thank you. Nikita has a question. What are some ways you were able to keep patients engaged long enough to finish the entire HCV treatment?
That's a great question. It's difficult, right? I think there's something unique about HCV in that it's a short, time-limited treatment. And I think this makes it a lot easier, right, to deal with than HIV, which is chronic and usually for somebody's entire life. And so with HCV, you can really push the message, A, it's a cure. Which we can't get with HIV, right? And B, it's only 8 to 24 weeks long. So that generally just makes it less challenging, to engage people in care. But I think a lot of the methods, Nikita, that you use, of course, not as robust, right? Within the clinic setting of texting people, calling people, emailing people, doing what it takes to get them in.
Thank you. So I'm going to go ahead and wrap us up. We are actually remarkably on schedule, which is really exciting. And I thank everybody for helping us in maintaining that schedule. So big thank you to Dr. Starbird and to all the speakers that we had in this first section following our keynote. We are going to take a break now from 11:28 to 11:38 to be really specific, so 10 minutes. And then we'll have some additional talks to spark thoughts, and Dr. Stephen Meanley will facilitate that. So go ahead, take a break, get some water or some more coffee, and we will reconvene at 11:38, and we'll look forward to seeing you then. So a big applause for all of our fantastic speakers this morning, and thank you for your continued engagement.